Okay, let's get started. Good afternoon. Welcome to Medicine Grand Rounds. Um, it's a pleasure to introduce both Dr. Kevin Deane and Dr. Kristen Demoruelle to you. This will be a tag team type of Grand Rounds. Both of them are working in the area of rheumatoid arthritis, biomarker development, early disease, as well as mucosal autoimmunity. And they both have a lot to say about this subject. So Dr. Demoruelle is an assistant professor of medicine in the Division of Rheumatology. She received her undergraduate degree from Delta State University and her medical degree from the University of Mississippi School of Medicine. She received her PhD degree from the University of Colorado in the Clinical Sciences program. Dr. Demoruelle participated as a House staff a member in our House staff training program, as well as in our fellowship training program in rheumatology. She has focused on early rheumatoid arthritis and on established rheumatoid arthritis associated interstitial lung disease. She's extremely well funded from the National Institutes of Health and was recently awarded a R01 on neutrophil extracellular traps in the lungs of patients with rheumatoid arthritis. Dr. Kevin Deane is an associate professor of medicine, and he is the Bill Arend endowed chair of medicine in the Division of Rheumatology. He received his bachelor's degree from the University of California in Davis and his MD degree from Loma Linda University School of Medicine. He also received a PhD in the Clinical Sciences program at the University of Colorado. He was a House staff member here at the University of Colorado, served as medical chief resident, and also did his rheumatology fellowship here within our program in the Department of Medicine. His research has focused on specifically mucosal sites of autoimmunity and on biomarker development, all focused on rheumatoid arthritis. He's well funded by the Department of Defense as well as the National Institutes of Health. And I think that Kevin is going to start off the discussion, and it'll go back and forth between Dr. Deane and Dr. Demoruelle.
Yeah, that's great. Thanks. And thanks to the department for letting us speak today on rheumatoid arthritis, pathogenesis, prediction, and prevention. So a few disclosures here, and then some evidence-based reviews, and you'll have these slides for reference to look at these later. So our primary goal today is we want to leave you with the enthusiasm that within the next few years, rheumatology is going to be taking new intent to prevent approaches for rheumatoid arthritis as well as other diseases. In our talk today, we're going to kind of work our way to that by first talking about the pathogenesis of rheumatoid arthritis, then elements of prediction, and then what's going on in prevention in the field now, as well as really leave you with opportunities and challenges and how progress is being made. So first off, I'll start off by talking a bit about what RA is. So it's a systemic autoimmune disease that the hallmark is inflammatory arthritis, which is painful, swollen, tender joints with synovitis as the pathology factor. Autoantibodies characterize the disease in about 80% of individuals with RA. Autoantibodies are good because they're both pathogenic, they're diagnostic as well as prognostic, and I'll talk a little bit more about those later as they actually are underpinning our ability to predict and prevent rheumatoid arthritis. Overall prevalence of disease about 1% if you look at all individuals. However, it's 3-to-1 in females versus males. And certain populations, such as first-degree relatives of patients with rheumatoid arthritis or indigenous North American populations, can have prevalence of up to 8%, so very high rates there. An individual's experience with the disease is joint pain, stiffness, and swelling, loss of mobility, as well as systemic features such as fatigue and malaise. Fortunately, things are greatly improved with treatments nowadays with good responses in most individuals, however, not perfect, and I'll talk a little bit more about that as we move along. Still with that, rheumatoid arthritis, once you get your first swollen joint, for most individuals is a lifelong disease with lots of healthcare visits, blood work loss. It's expensive, on average $15,000 a year per individual. There's treatment side effects, great disease doesn't happen in all individuals, and there's a lot of comorbid conditions, including premature heart disease, osteoporosis, and infections, as well as lung disease. With all that in mind, most people who have RA wish they'd never gotten it, and they're really interested in not having their family members get it. And that's going to, again, those sentiments are going to underpin some of the moves towards prevention. So here's a couple pictures of people with rheumatoid arthritis. Up here is someone with subtle disease, but feeling the symptoms of pain, stiffness, and swelling that can impact their work. Down here is some more dramatic disease, early onset with marked swelling in and around certain joints like the MCPs. Over on this side, an individual with marked swelling at her PIPs. Underlying this on x-rays, we can see what we really hate about rheumatoid arthritis is that the disease pathogenesis and inflammation can lead to great destruction of joints if it's untreated. On the left here is a normal x-ray showing nice joint spaces, very well preserved joints. Over here is long-standing rheumatoid arthritis with just basically obliteration of those joints, leading to extreme loss of function. There's, of course, additional manifestations of rheumatoid arthritis. One of the major ones is lung disease. Interstitial lung disease on the left is one of the more feared complications. Fortunately, not that common. But what's emerging is that there's other forms of lung disease, including airways disease, that's quite common across all rheumatoid arthritis, and estimates of 50 to 70% of people will have some form of airways disease. This actually is a clue towards pathogenesis, and Kristen Demoruelle is going to talk a little bit more about that in the next few slides. So I mentioned autoantibodies. There's two systems we commonly use in rheumatoid arthritis, both in clinical care as well as research. Rheumatoid factor, it's been around for over 40, 50 years. It's about 80% sensitive for disease. The problem is it's 80% specific, so it can be present in a lot of other conditions, and that low specificity makes it not great for a predictive marker. Fortunately, in the last decade, we've discovered a new antibody system. It's abbreviated ACPA, or it's antibodies to citrullinated protein antigens. And then the commercially available version of this, which most people are familiar with, is the anti-CCP antibody here. It's still only about 80% sensitive for disease, but where it's really performing nicely is it's quite specific for rheumatoid arthritis, both as a diagnosis if you have someone with inflammatory arthritis that makes highly likely that they have rheumatoid arthritis as a cause, and also it's very predictive, which I'll talk more about in the next few slides. So citrullation, we are not all familiar with this. This was an amino acid we didn't learn about in med school, most of us. So citrullation is something that happens in all of us all the time as part of normal wound healing, apoptosis. It's why we have fingers instead of webbed hands, because it allows us to retract the webbing in our fingers. But immune responses to citrullation are highly specific for RA. So while we all have citrullation, immune responses to that are unique. So the process of citrullation is a post-translational modification of the amino acid arginine through the action of the enzyme peptidyl arginine deaminase, or PAD, to citrulline. Then that citrulline residue gets put into proteins and peptides here with flanking sequences. And this, as I'm circling with the red pointer here, becomes the target for immune responses. Now, lots of different peptides and proteins can contain these sequences, such as fibrinogen, vimentin, enolase, histones. All of these can be targeted both by T cells in rheumatoid arthritis, as well as B cell and antibody responses, and anti-CCP is one of these that target that residue. So I'll jump back to a little bit of clinical care, and then we're going to drive into more of the pathophysiology shortly. So how is rheumatoid arthritis treated now? Well, the paradigm of disease is that we wait until somebody is sick with clinically apparent inflammatory arthritis. This is someone who has joint pain, stiffness, and swelling, gets noticed by their primary care, referred to rheumatology. Then we apply disease-modifying therapy. Ideally, if we can get it started within 3 months after the onset of symptoms, we have best outcomes. And then therapy is based on a growing understanding of the biology and natural history of RA. Now, I'm not going to drill into the specific therapies for RA in great detail today, but basically what we want to do is capture someone with early disease, although this lady has still a little bit of damage. And instead of just letting natural history progress where we'd see this very damaging disease, we want to intervene with our variety of disease-modifying agents, including steroids all the way down to B-cell depletion, to try and halt this process from moving to this process. What we've also learned is that catching this even earlier, before there's even subtle damage, can lead to longer-term outcomes. And that has helped actually underpin even moving back further into prevention. Now, I think a lot of our grand rounds have a case. Here's where our case is. That's going to highlight the next phase of rheumatoid arthritis that we want to talk about, which is pre-RA. So here's a 47-year-old female whose mom had rheumatoid arthritis, so familial risk for disease. She's had some aches and pains for the past few months on her hands, feet, sometimes shoulders, a bit of morning stiffness. But on examination, she has no tender or swollen joints consistent with inflammatory arthritis. So we would not classify her as having rheumatoid arthritis. However, on antibody testing, she has a very high level of anti-CCP as well as an elevated level of rheumatoid factor. So this case exemplifies this new stage of rheumatoid arthritis that we call pre-rheumatoid arthritis, where she's exhibiting autoimmunity but doesn't have the classic features of disease. And this moves to this slide, which now gives us our current model of how we think rheumatoid arthritis develops, including with this pre-RA phase. So we think genetic and environmental risk factors combine to trigger systemic autoimmunity that may or may not be associated with initial aches and pains that over time progresses initially to what you would see in clinic as inflammatory arthritis and say, yes, you have inflammatory arthritis that might not meet classification criteria, but over time, joint involvement would accumulate and that individual would meet classification criteria that we've got established by well recognized criteria such as the 2010 or 1987 criteria. And this is the point at which we'd call you rheumatoid arthritis and treat you as such. So this case would fall in this range, this pre-RA period where she's exhibiting systemic autoimmunity, aches and pains, but does not have the inflammatory arthritis that classifies RA. So we've learned about this stage of pre-RA through several studies across time. There's been well-developed prospective natural history studies, and I like this one of the Kamel O'Donnell people, formerly known as Pima, and these a high prevalence RA population that's in Arizona, where basically they published in 1988 off a 20-year study that basically gives us this model of RA where biomarkers and other risk factors precede the onset of inflammatory arthritis. Several other studies, including one by our own group here at the University of Colorado, has contributed to understanding this model. And importantly, we have ongoing prospective studies that Kristen is going to talk to a little bit more about under the umbrella here at the University of Colorado called the Studies of the Etiology of RA, or SARA. This is headed by my boss, Mike Kohlers, Jill Norris, myself, and I say cast of thousands, which is not a joke. We've actually literally had thousands of subjects contribute to give us our models of rheumatoid arthritis, and we're grateful to that. So this gives us not only this model, but understanding of the pathophysiology of rheumatoid arthritis that in brief is that there's an initiation and propagation of autoimmunity long prior to the first swollen joint. This figure is kind of complicated, but I'll walk you through it. We've developed this out of a sample set we got from the Department of Defense a few years back, where this blue line represents over 200 individuals who developed rheumatoid arthritis with multiple time points. And then this red line represents healthy controls. So what we can notice is this CCP test that I've talked about earlier, this antibody test, rises very early. In fact, separates out from control 17 years before a diagnosis of rheumatoid arthritis. Rises a bit, holds steady, and then in 3 to 5 years before rheumatoid arthritis really takes off, and that's corresponding with symptom onset. And finally, these individuals cross a threshold and RA is diagnosed. Now, along with this, in addition to the anti-CCP, other antibodies and other factors are developing, including rheumatoid factor, other antibodies, which I won't talk a lot about today. Inflammation in the form of cytokines, chemokines, T and B reactivities are all increasing. So basically driving an initial break in tolerance and expansion over time to the point at which clinically apparent disease develops. Importantly, though, during that model, there is no inflammatory arthritis during much of that pre-RA period. And this is based on studies that looked at exams, imaging, as well as joint biopsy, driving a hypothesis that RA-related autoimmunity really starts outside of the joints. And due to a variety of things that Kristen is going to talk about in more detail next, is that we think this is highly likely to be mucosal sites. So really disrupting how we think about RA as an articular joint, at least in one phase, to a mucosal disease early on. And with that, I'll turn it over to Kristen for the next set of slides.
Hey, thanks, Kevin. Thanks for setting that up. So I'm going to talk about the mucosal sites and their involvement in rheumatoid arthritis development. And as Kevin mentioned, now that we understand that systemic autoimmunity is present years before there's any signs of joint inflammation or rheumatoid arthritis, it really points towards a site outside of the joints where this whole autoimmunity and the whole process gets started. So mucosal sites are of particular interest because they're sites where the environment and your immune system are constantly interacting and can lead to inflammation and antibody generation. Importantly, there's a lot of different mucosal sites where this can occur, and I've listed some of the ones here that are of interest in rheumatoid arthritis, including the periodontum, lung, intestine, and the genital tract. And I'll talk briefly about each of these and what we know about their contributions to the development of rheumatoid arthritis. So I'll start with the lung because that's one that's been long associated with rheumatoid arthritis. Studies back 10, 20 years ago have really looked at it in established RA, so individuals who have already developed the joint disease of rheumatoid arthritis. And in those studies, it's been shown that there's a very high prevalence of both airways disease and parenchymal abnormalities when doing lung CAT scans on individuals with rheumatoid arthritis. This occurs even in the very early stages of rheumatoid arthritis, so within a year of diagnosis. There's also an increased prevalence of interstitial lung disease in patients with rheumatoid arthritis that's quite a bit higher than the background in the general population. And studies have also found an increased prevalence of airways disease, including asthma and COPD in patients with rheumatoid arthritis compared to the general population. So here, as Kevin mentioned, we're very interested in this pre-RA phase and wanted to ask the question of how the lung might be involved in the initial generation of autoimmunity during pre-RA before an individual actually has any evidence of joint inflammation. And so a couple of years back now, we did a study where we did high-resolution CAT scan imaging of the lungs in individuals who had pre-RA, so systemic antibodies in the absence of any inflammatory arthritis, and compared those to controls. And what we found, which is demonstrated in the picture here, is that there was a high prevalence of airway abnormalities on lung imaging in these individuals, 76% having some airway abnormality, compared to those the controls who only had 33% of those individuals having some evidence of inflammatory airway abnormalities. Since that time, there's been several studies from several other groups that have looked at airways disease and its risk for rheumatoid arthritis, and studies have shown that both asthma as well as COPD are both risk factors for developing RA in the future, sort of further solidifying the importance of the lung airway during this pre-RA period. For our studies here, we were next interested to look at what might be going on in the lung, and we used induced sputum to look at the biology of what was going on in the lung of these individuals during the pre-RA period. We've had a few studies along these lines, but to kind of summarize them with one figure here, when we looked at induced sputum samples in healthy controls, individuals who are at risk for RA. So in this case, it includes individuals with the systemic autoantibodies without inflammatory arthritis, but also those with a family history of rheumatoid arthritis, so having a genetic risk for developing RA in the future. And we compare those to individuals with rheumatoid arthritis as well. We looked at the anti-CCP levels in the sputum of these individuals and found that a portion of those at risk for RA had high levels of anti-CCP in the lung, which was even higher in individuals with rheumatoid arthritis. Importantly, in this study, the open circles represent individuals who are serum anti-CCP negative. So what's very interesting in that regard is that several of these individuals have very high levels of anti-CCP in the sputum, but don't have any presence of anti-CCP peripherally in the blood, supporting that these antibodies, at least in a portion of individuals, could be initially generated at the lung, supporting this hypothesis that the lung could contribute to this early development of autoimmunity prior to the onset of any inflammatory arthritis yet. Our team here is also very interested to understand what could be triggering these anti-CCP antibodies or other RA-related antibodies in the lung during this pre-RA period. And we focused a lot on something called neutrophil extracellular traps, or NETs. This is a process by which neutrophils decondense and expel their chromatin in complex with intracellular proteins. It's a very common occurrence in the settings of infection or inflammation. But importantly, related to rheumatoid arthritis, NETs externalize proteins, and some of those proteins can be citrulline. As Kevin mentioned, citrulline proteins are the antigen targets for these anti-CCP antibodies that are very specific for rheumatoid arthritis. It's also been shown in several studies that individuals with established rheumatoid arthritis, their neutrophils are more prone to undergo netosis, And these studies have looked at both the lung and the joints. No one's yet looked in the lung, and so we wanted to look in the lung and see if this was a contributing factor to the anti-CCP antibodies that we're seeing during this pre-RA period. So our work in this area, just to briefly demonstrate some of the interesting findings here, we looked at net formation in individuals who were at risk for rheumatoid arthritis, as well as those with established RA compared to healthy controls. And we saw that the neutrophils that we obtained from the sputum of these individuals were much more prone to undergo net formation in ex vivo unstimulated assays compared to the controls. This slide is showing not only net formation, but these are specifically nets that are staining positive for citrullonated proteins. In these studies, we use staining for anti-citrullonated histone H3. We then looked at the correlation between the anti-CCP antibodies that we see in the sputum and the net remnants based on a DNA, in this case, citrullonated histone H3 complex in the sputum in our at-risk individuals. And we see a very strong correlation between the anti-CCP antibodies and these citrullonated protein containing nets. So these studies have really supported that net formation appears to be important in the lung during this pre-RA period, particularly in association with anti-CCP antibody generation. And we found that all nets are not created equal, that some contain different proteins than others. And it really appears to be these citrullonated protein containing nets that might be very important for the initial triggering of these anti-CCP antibodies in the lung. Going forward in our SARA-related studies, we'll be looking at the different factors that could trigger these nets, and particularly the citrullonated protein containing nets in our pre-RA individuals. Also looking at net clearance, which appears to be an important factor as well. Our hypothesis is that distinct factors will increase citrullonated protein expressing nets, and that there will be decreased net clearance in the lung in these pre-RA individuals, and that both of those factors are likely contributing to the generation of anti-CCP antibodies and potentially ultimately RA. What's really exciting and important about these studies is that if we can understand how this is involved in the early phases of rheumatoid arthritis, they may be novel targets for treatment as well as prevention, which Kevin will talk about more at the end of the talk. So moving on from the lung, to mention another mucosal site that's particularly interesting to us here is the female genital tract. So it's well known that women develop RA about 3 times more often than men. This is particularly increased in prevalence in premenopausal aged women compared to younger men. And despite decades of research that have looked at systemic sex hormone levels, have looked at genetics, there's really not a clear understanding of exactly why RA occurs more often in women. And so, as Kevin mentioned, we have this mucosal origins hypothesis that autoimmunity in RA starts at a mucosal site. And while a lot of work in the area has involved other mucosal sites, we thought new concepts were important to bring to this area and try to understand if sex differences in RA may be explained by unique mucosal sites that women have that men don't. And so we're pursuing a hypothesis that the cervicovaginal mucosa may be a unique mucosal site in women where autoimmunity might originate and could contribute to this increased prevalence of RA that we see in women. So to briefly mention some of the work that we've done here, which has been very exciting, we, similar to the sputum studies, looked at rheumatoid arthritis patients, those at risk for RA and healthy controls, and measured anti-CCP levels in the cervicovaginal fluid of these premenopausal women. Similar to the sputum, we found high levels of anti-CCP antibodies in RA individuals, but also elevated levels in a portion of those at risk for RA, and even in this case, in a portion of healthy controls. Importantly, in the individuals without RA, we saw that these anti-CCP levels in the cervicovaginal fluid strongly correlated with local signs of inflammation. In this figure showing IL-6 levels here. And so these data have shown us that anti-CCP appears to be present in this mucosal site that's specific to women, both in women with established rheumatoid arthritis, but also those without. And we're very interested to pursue this further to understand how this is contributing to the generation of autoimmunity as well as rheumatoid arthritis in women. I'll next mention the postpartum period, which is another sex-specific factor in rheumatoid arthritis. So the incidence of rheumatoid arthritis is quite high in women during the first year after childbirth, while the overall average age of getting rheumatoid arthritis is close to 50. In women who do get it in the premenopausal years, a large portion of them get it during the postpartum period. So there's clearly something going on during that time period that's increasing the risk of developing rheumatoid arthritis. The mechanism for this is really unknown. And so again, employing this hypothesis that RA starts at a mucosal site, we wanted to look at the mucosal sites that are specific to the postpartum period in women, including breast milk as a representative sample of the lactating mammary tissue, and the cervicovaginal fluid that I mentioned in the previous slide, in women who were in their first year postpartum. And our early results from this appear to be very interesting. In these women who don't have rheumatoid arthritis, we see that there are detectable levels of anti-CCP in breast milk. And when we looked in the cervicovaginal fluid of the postpartum women, the anti-CCP levels were much higher than in premenopausal women who were previously pregnant but were not in the postpartum period. And again, these are, it's kind of a new area that's being explored by our group here. And we're very excited to try to understand this more and see if we can understand more about the biology that occurs during the postpartum period that could give us insight into why this period has such an increased risk for developing rheumatoid arthritis in these women. I'll briefly touch on the oral and gut mucosa. Other groups have looked at these two sites quite a bit as well. There's a lot of data to link the gingival mucosa with anti-CCP generation of rheumatoid arthritis. In particular, this is another mucosal site where anti-CCP has been identified to be present in the absence of rheumatoid arthritis, and particularly in patients with periodontitis. So inflammation, they've been able to find anti-CCP antibody levels in some of these individuals in the gingival crevicular fluid in periodontitis patients. There's also two bacteria that have gained a lot of attention over the last several years because of some of the potential mechanisms by which they might contribute to the development of these antibodies during the pre-RA period. One of those is Porphyromonas gingivalis, which expresses its own PAD enzyme. As Kevin mentioned, PAD's the enzyme that citrullonates proteins. And so this has been a bacteria that's associated with gingivitis and periodontitis and has been looked at as a potential trigger of autoimmunity in rheumatoid arthritis in some individuals. Another bacteria that's gained some attention in the last few years is Agricobacter, which expresses a leukotoxin that can hypercitrullonate neutrophils. So sort of another way that a bacteria could contribute to an increased citrullinate protein presence at a mucosal site that could then trigger an autoimmune response to that citrullinate protein. The gut mucosa in general, the data here have really focused on the microbiome for the most part. So there's been some studies that have found one bacteria of particular interest called Prevotella capri in individuals with early untreated rheumatoid arthritis. It's been found to be expanded in abundance there. And then another study that's shown activation of T cells in rheumatoid arthritis. Work by a colleague in our division here, Dr. Christy Kuhn, has been looking at this in our pre-RA individuals. And she's been able to find that anti-CCP does appear to be there in the stool of some of these individuals, as well as she's been finding some distinct bacteria that appear to be associated with anti-CCP antibodies during this pre-RA period. And so another site, of interest. So to kind of summarize those quickly, there's multiple mucosal sites where RA-related autoantibody generation has been demonstrated in the pre-RA period. And in particular, a lot of these individuals don't have systemic autoimmunity, really supporting that these could be initial sites of antibody generation during this pre-RA period. Important studies going forward, which we're working on here, are to look at multiple mucosal sites at the same time to understand their connections to each other or individually and how that contributes to the development of RA. Another important point is that, as I highlighted, there's a modest portion of healthy controls that seem to have elevated anti-CCP levels at these mucosal sites, we know that they will not all, many of them will not develop rheumatoid arthritis, and it leads to what we've begun to understand as perhaps a natural mucosal response to local inflammation and citrulline proteins may be occurring in lots of individuals. We've seen that with the resolution of that inflammation, that these autoantibodies often resolve. And so it's really led us to have kind of a new take on this with the hypothesis that dysregulation of what may be a naturally occurring mucosal immune response with the generation of anti-CCP antibodies to citrulline proteins associated with inflammation could, in some individuals, progress to an aberrant anti-CCP generation if either inflammation is not resolved or if that inflammation triggered a response that doesn't self-regulate. And ultimately, this could then lead to rheumatoid arthritis. I'll end with a slide to kind of finish talking about the mucosal sites. I mentioned some of the work in different areas trying to understand these mucosal sites and their contributions to the development of autoimmunity in the pre-RA period. But one question is whether or not we can use this identification of immune dysregulation at different sites to predict rheumatoid arthritis development. And in some work that we're doing here, we've had 49 serum anti-CCP positive pre-RA individuals. So they're at very high risk for developing RA in the next few years. We followed them for 3 years and 20% of them have developed RA. And when we looked at different baseline factors as to understand what was strongly associated with those who developed RA, one of the things we found that were in the baseline samples, so before they developed inflammatory arthritis, the presence of anti-CCP or rheumatoid factor, one of the other RA-related antibodies that Kevin had mentioned. In those who developed RA, 78% of them had an antibody present in their sputum, compared to only 20% in those who did not develop RA. And so it was actually quite predictive of identifying within a very high risk group who was going to develop RA in a short period of time within 3 years. And so this is very exciting. We're interested to look at this in more detail. Kevin's going to talk about prevention, but the other very exciting thing here to consider is that perhaps if this inflammation and autoimmunity at a mucosal site such as the lung is contributing to the progression from pre-RA to the development of joint disease and rheumatoid arthritis, it may be that when we go to prevent rheumatoid arthritis, we actually need to potentially target these mucosal sites where this early inflammation and immune dysregulation is occurring. And with that, I think I'll turn it back over to Kevin to finish things up.
Hey, great, Kristen, thank you. So I'm going to resume the last portion of the talk. I was going to talk a bit about prediction and prevention by getting back to our case. So remember, this is a 47-year-old female who has aches and pains, but no inflammation in her joints consistent with active inflammatory arthritis, but she's got these elevated biomarkers. So again, this case and others like it have really underpinned where we want to go next with the field, which is identifying how we can both predict the risk for future rheumatoid arthritis and then ultimately prevent. So in terms of prediction of future clinically apparent rheumatoid arthritis, while Kristen talked about sputum antibodies predicting it, we have a lot more data using serum autoantibodies to be able to predict future onset of rheumatoid arthritis. And in particular, multiple case control and prospective studies have now demonstrated that serum elevations of, in particular, the anti-CCP assay, have positive predictive values, 30 to 60%, depending on the study, for clinically apparent inflammatory arthritis within 2 to 6 years. Now, this is a pretty powerful predictive value and has really underpinned our ability to say, with fair degree of certainty, someone's going to get inflammatory arthritis and then have confidence to intervene to try and prevent future disease. This can even become a higher positive predictive value if symptoms are present, rheumatoid factor is also positive, and certain genetic factors, which I won't dwell on a lot, but certainly open for questions at the end. So back to the case presentation, this particular individual has a greater than 50% risk for developing clinically apparent inflammatory arthritis within the next 3 to 5 years. And that gets us to prevention. That's really underpinned by what I've just discussed. Prediction models where we can identify with fairly high accuracy someone's going to get rheumatoid arthritis within the next few years. Also, we're able to use established therapies that we know work in established joint disease and that should work in this pre-RA phase, and an ability to identify at-risk subjects. So increasingly across the globe, people with aches and pains are being identified as being CCP positive, as well as other natural history studies, such as the studies of the etiologies of rheumatoid arthritis or SARA, are finding these people that we can now plug into prevention studies. There's one very important prevention study in rheumatoid arthritis that has already been completed, and it was published in 2019. It's called the Prairie Study. In inclusion here, they had 81 subjects. All of them had aches and pains or arthralgia, but none had inflammatory arthritis on joint examination. All were anti-CCP and rheumatoid factor positive, kind of putting them in that window right before they're going to get clinically apparent inflammatory arthritis and rheumatoid arthritis. The intervention was placebo-controlled rituximab, 1,000 milligrams once, or placebo. The major findings was this: in the rituximab arm, that infusion of rituximab, the B-cell depleting agent that we often use for rheumatoid arthritis, delayed the onset of clinically apparent inflammatory arthritis. However, it did not overall prevent disease. This was still thought to be a great success because the trial was able to identify at-risk individuals, convince them to take an infusion therapy, as well as delay the onset of disease with minimal safety issues. So this really spurred the field to move forward with prevention. And as of right now, there's multiple other ongoing RA prevention trials. Unfortunately, none have completed, so we don't have data to present. This will be a talk for another couple of years, but there's multiple trials ongoing. Number one is Stop RA. We're particularly proud of that. We developed and launched that here at the University of Colorado. Now it's the first prevention study in RA in the United States. There's multiple other studies in Europe, in the United Kingdom, including APIPRA, Stop RA, Treat Earlier, and a trial is just getting launched in Canada called CUPRA. Each of these is testing a different intervention. We're using hydroxychloroquine. Abatacept's being used in the United Kingdom. Atorvastatin or statin is being used in the Netherlands. That's based on, we know that atorvastatin and other statins, to be honest, have some immune modulatory effect and may be very effective in this early period. Methotrexate's being used and Treat Earlier. And then the Cooper one is unique. It's using sort of nutraceuticals to intervene on this early period, including curcumin, omega-3, and vitamin D. All of these use as an outcome inflammatory arthritis that's classifiable as RA by established criteria, the exception of the last one, which is actually looking at just the biomarker outcome, which actually was an important advance to be able to use that as a surrogate for a meaningful alteration of the immune system. Again, all these are underway. We're going to hopefully get the readout in the next couple of years. I'll spend a bit of time on Stop RA, which is, again, we're proud of this. It's our trial. It's funded by the NIH, NIAID, and through the Autoimmunity Center of Excellence. The gist is we identify people who are anti-CCP positive without inflammatory arthritis. They receive hydroxychloroquine for 1 year and then are followed for 2 years after that to assess durability of response. Importantly, to find individuals for this, and this is a challenge to the field going forward, we've screened 30,000 people across the United States in the past 3.5 years to randomize 130 people into the trial so far. So it's been a lot of work. We're very excited. We've gotten 130 people enrolled and things are going well. So we hopefully will have a readout in the next couple of years on this trial. More information is at our website, www.stopra.org. Now, importantly, each of these trials have different targets and different times that they're intervening in the stages of rheumatoid arthritis. This is that model I presented earlier. Sort of line the trials up here. They're all intervening in the systemic autoimmune phase with and without aches and pains, all trying to prevent the first swollen joint. But an important part of this is all these interventions that we're using are based in science and in convenience. All these agents are approved for use in rheumatoid arthritis, and therefore were easy for regulatory bodies to say, sure, go ahead and use that in a preventive way in this disease. So we've basically taken drugs we know work in this scenario back to this earlier phase when we're having propagation of autoimmunity, but not inflammatory arthritis. Now, these may work, and we're very excited to see how the clinical trials are going to turn out. However, as Kristen talked about, if truly the key processes at this early phase are not articular but mucosal, we really have to understand this period to identify novel targets at this early stage and hopefully more malleable stage to be able to truly intervene and prevent future rheumatoid arthritis. Importantly, as Kristen discussed, these may be quite sex-specific interventions. They may be mucosal specific. And as we're learning more as our natural history studies progress, there may be unique processes that are actually very important at this very early phase that might not necessarily be something we target in a later phase. And an example of this is fatty acid metabolism and resolvins. So we know if you give somebody with established rheumatoid arthritis from randomized controlled trials that fatty acid supplementation with omega-3s reduces inflammation a little bit, but it's not by any means a major form of treatment. However, we've noticed in this earlier phase, through work done here through studies of etiologies of rheumatoid arthritis, and Ryan Gann, who is a grad student who worked with us, that fatty acids seem to be very important in this period and indeed are related to the generation of autoantibodies and intake of omega-3s, and higher levels of omega-3s is associated with less progression to the development of inflammatory arthritis. So again, while these would not be something you'd treat in established disease, they may be very important in this early period of disease to block or halt or delay the initiation and propagation of disease. I'm going to wind up here with a few comments about the major challenges and opportunities left for prevention. This is 6 out of a list my colleagues and I had of about 50, but we think these are the key ones. Most importantly, we think, what will these current trials tell us? We're going to learn a lot about how prediction works in real time in these prospective trials. We're going to see how they respond to the agents we're using. They will hopefully identify novel targets for disease. Fortunately, all of these prevention trials in rheumatoid arthritis have embedded within them mechanistic studies that are going to help us learn more about how RA develops. So the next round of trials will have more detailed targets or unique targets in prevention. Also, as part of the trials, we're building infrastructure to do more trials. I mentioned for Stop RA, we've screened 30,000 people to identify individuals to randomize. I think we're going to build on the things we've learned in that process, so the next trial is going to be easier, faster, and cheaper to do. We'd like to learn examples from type 1 diabetes, which I think some of you are probably familiar with, their network called TrialNet, which basically gets a lot of people tested for type 1 diabetes autoantibodies and tees them up to participate in clinical trials, an example of which was the teplizumab trial, which came out in the New England Journal last year. The other big thing we want to learn from these trials is, what is success in prevention? If you noticed that when I talked about that, all of the interventions in these trials were limited. It was a sort of a shoot the moon approach, where an intervention for a limited time may help reset the immune system and lead to long-lasting a benefit in prevention of RA. Now, unfortunately, we learned from the rituximab trial, the Prairie study, that it's maybe going to take more than one time or a limited intervention to delay or prevent disease. Still, that could be beneficial, because stopping the first flare of RA and continuing therapy still may be beneficial, because we'd avoid some of that early damage that occurs with the first joint inflammation. Individual preferences and delivery are going to be incredibly important. We've learned a lot in our process with Stop RA, and the other trials have as well. Finding people who are at risk for rheumatoid arthritis, having them be willing to get tested for their individual risk through CCP testing, and then participate in a trial is extremely difficult, but we're learning a lot, and I think we're very successful. The PIPRA study has actually finished enrollment in the UK, so we can find these people, we can get them to be enrolled, but we're going to learn a lot about this. Especially, we're going to know how to apply this in high-risk groups, including racial groups, women, and family members, who are really the people we would want to intervene in first. We're all looking forward to seeing how the trial in Canada works with a very high-risk Indigenous population, because I think those will be the groups that we're going to want to target when in clinical care for prevention. We ultimately want to expand this to other diseases. As you know, RA is only 1% of the population, but autoimmune diseases can affect up to 5 to 8% of the population. And there's current trials in prevention in lupus and psoriatic arthritis as well. We're looking forward to the results there, so we can maybe expand this out to a variety of autoimmune diseases. And finally, while I mentioned the current trials are probably most important, business models are also exceedingly important to drive this forward and to really enact a change in how we manage rheumatoid arthritis. This will require input and agreement from public health, insurance, pharma, and diagnostics, all to build business models to say, how can we effectively and cost effectively implement prevention? And in conclusion, we've talked today about rheumatoid arthritis, its pathogenesis, and especially the role for mucosa in the initiation and early propagation of disease, some aspects of prediction, and then where we're at with prevention. Now, prevention may leave you wanting more, but certainly I think a lot of these trials that are ongoing now should be coming out in the next few years and really inform how we move ahead. In particular, I'm anxious to see how we can understand the pathogenesis of disease and how mucosal factors may ultimately impact prevention. So you can envision we may not give a pill in the near future for prevention of rheumatoid arthritis. We may be able to target specific mucosal processes that are precise for the certain individual, whether it's sex specific or otherwise. There's certainly opportunities ahead as well as challenges, but I want you to leave this visual in your mind here where hopefully soon we'll be able to take at-risk populations and stop them from progressing to this clinical form of inflammatory arthritis that can be so devastating. I'm going to show you a few slides of our group that's helped put all of this together. This is the studies of the etiology of rheumatoid arthritis based here at campus. This is a fairly recent photo. We're getting people added on as we go. We didn't have photos for everyone, so here's the larger list as well as our extended collaborations. Notice there's a blank spot over here for more collaborations, because as we move forward in prevention, we'd love to talk to more people and bring more people on board with prevention and autoimmunity. We thank our funders. The NIH in the Autoimmune Centers of Excellence is currently funding our clinical trial. We've had a lot of support from a lot of different other agencies, including the Department of Defense, Arthritis Foundation, NIH in multiple levels. Recently, we've had new funding from the Allen Institute for Immunology, all supporting our efforts in this area. And with that, I will open it for questions.
Okay. Well, that was a fantastic presentation. Thanks, Kevin and Kristen. Really superb work, and we do have a lot of questions. So let me just put the first question out there. These series of questions focus initially on anti-CCP antibodies. Given the homeostatic role of citrullinization, tell us a little bit tell us why more people don't have these antibodies, and why it's just focused on individuals with disease.
Kristen, I'll take this to start and then I'll hand it off to you. So it's a great question. We think that more people develop these than we think. But it might be in sites that we're not used to checking. As Kristen talked about, mucosal sites, actually these antibodies or immune responses may be quite common as part of homeostasis. But what we think is the aberrancy is taking that from a mucosally located process, transforming that from perhaps an IgA mucosal-based response to an IgG and then systemic response is where the pathogenesis lies. And those steps that take it from that normal homeostatic to pathogenic are what we're needing to learn now. Are these genetic factors? Are there additional environmental factors that help drive that? But we think that while it's a common process and even autoimmunity to it may be quite common, the next pathogenic steps are probably more rare and related to complex interactions between genes and environment.
Yeah, I think I'll just add to that the immune response and particularly a sustained immune response to the citrullinate protein seems to really make an effect. We look at different isotypes of antibodies. The generation of an IgG antibody to CCP seems to be most strongly associated with progressions to RA. Also different modifications that occur on the antibodies, glycosylation patterns and things like that. So there's probably a lot of contributing factors that take someone from a homeostatic state into disease. Genetics probably play a role. There's been a lot of studies to look at how some of the genetic associations in rheumatoid arthritis may specifically contribute to an individual's immune system taking a citrullinate protein that again is occurring naturally in many places and presents that to the immune system in such a way that triggers an immune response. There's also, just to finally mention, there's some data that suggests that not all citrullinate proteins are targeted. So there's certainly a few that we know are particularly important, different citrullinate proteins. And it may have a lot to do with the flanking amino acids along the front and back ends of the citrulline as to how the immune system's able to target those particular citrullinate proteins.
So Kristen, you mentioned in your presentation that ongoing inflammation might play a role in terms of establishing anti-CCP antibodies that are systemic. There are a lot of inflammatory lung diseases, asthma, COPD, bronchitis, where individuals don't develop rheumatoid arthritis. Why would you have an ongoing inflammatory response and not see an increase in the anti-CCP antibodies systemically?
Yeah, it's a good question. Again, a lot of the RA work has really focused on the interstitial lung disease in the past, and more recent work has been looking more at these airways disease. While it's not tremendously increased, there is an increased risk of developing rheumatoid arthritis in those who have asthma and COPD compared to those who don't. So there probably is some contributing factor to that ongoing airway inflammation. It just doesn't seem to affect all individuals. So is it genetics? Is it continued smoking? Are there other factors that take someone from kind of a little inflammation to something that really pushes them over the edge? But yeah, I think it's a great question as to why some individuals, but not all. But it is increased, so there does seem to be some signal there that in some individuals something is pushing the process forward.
Could you comment a little bit more specifically on the role of cigarette smoking?
Yeah, this is Kevin. I'll take that. So, cigarette smoking is a powerful risk factor for rheumatoid arthritis, and we think globally it explains about 25% of disease, and particularly it seems to be associated with the CCP positive disease. So there's some models where cigarette smoking can engender citrullination in the lung, and in the right genetic background, that citrulinated proteins then may be more readily presented to the immune system to trigger immune responses. So we think cigarette smoking plays a key role in that. That said, it's still only 25% of disease, and people can mount CCP responses and not have exposure to cigarette smoke. So it's an important model, I think, to understand, but it's not the only model. It also makes us wonder is it cigarette smoking that's driving this, or is there other mucosal changes that other types of inflammatory process, whether they're microbiologic or other environmental toxins, could still trigger similar pathways? So a summary to that is it's an important risk factor, and it gives us a good model. However, it doesn't explain everything, although we certainly do advise in prevention. If one is at risk for rheumatoid arthritis, smoking cessation is probably the most powerful intervention to stop your progression of disease until we learn what drugs can work. So it's still an important preventive measure.
What about specific HLA alleles and anti-CCP antibodies?
So there are a strong association between specific alleles. There's a set of alleles in the HLA system that are called in collection the shared epitope, that are all fairly similar risk across rheumatoid arthritis, that seem to be able to present citrulinated proteins better to the immune system than other non-shared epitope alleles. And that may be playing a key role in driving forward immune processes. However, it's not clear what role it plays or exactly when it acts in rheumatoid arthritis. It may not actually be part of the initial triggering of CCP-related autoimmunity, but it may allow for propagation and expansion and epitope spreading of disease and amplification of immune responses later, or also promote T-cell health. And as a promotion to a Thursday talk coming up, I think it's this week, out of Brian Freed's lab, they're going to be talking at the Thursday conference in the Department of Medicine. I think a little bit more on that topic.
I think we only have a couple more questions about anti-CCP antibodies, but it's generated a lot of interest. Are these antibodies involved in the pathogenesis of RA, or do they just serve as biomarkers?
Kristen, do you want to take that?
Yeah, maybe we'll go back and forth. Yeah, in the past, that's been a big question. Are they just a biomarker or pathogenic? It appears that they're probably pathogenic. There's been some work in the CIA models by Christy Kuhn here several years ago that really demonstrated that they seem to be pathogenic in joint disease. And more recent studies have found that they can have such pathogenesis, such as activating osteoclast which could contribute to some joint damage. It's not quite clear exactly how they contribute, but it does appear that they contribute to pathogenesis. Even in kind of correlative studies, the higher the CCP level, the presence of CCP is associated with more severe rheumatoid arthritis, which certainly suggests that they're pathogenic, but some of the more mechanistic studies have started to look at exactly how they're contributing, with current work really focused on osteoclastogenesis, but some data probably coming out soon on its roles in macrophage function and other cell dysregulation.
So how do they respond to therapy?
Individuals with CCPs?
Yeah. How
Yep.
did any
It's a good.
difficulties track with therapy, with response to therapy?
Yeah, that's a good question. To plug the prevention side of things even more, if we don't routinely check anti-CCP antibodies clinically because they stay there for the most part. They don't seem to track with disease. People can have very well-controlled disease on our therapies, and their CCP levels don't always change. That makes you think that something has happened that you can't turn off. You can control with treatment, but it's gotten to a point where it's so self-propagating that we can't actually cure the disease and make it go away, which is one of the big pushes for prevention prior to the onset of joint inflammation, that maybe we could actually reset the immune system and maybe these antibodies would then go away. But at this point with established disease, they don't tend to go away. Individuals with anti-CCP positive rheumatoid arthritis are more difficult to treat. They're more difficult to treat and also more difficult to get into what we call DMARD-free remission. So if we try to remove the treatments that we're using, anti-CCP positive individuals are more likely to flare. So again, sort of supporting that they may be involved in pathogenesis because they didn't go away. And once we take the meds off, those are the patients that tend to flare more likely.
Kevin, did you have something you wanted to add?
I would add, it might also be related to how we're able to assess these antibodies. Right now, commercial assays are kind of limited. We are realizing if you can tease out these CCP responses, there may actually be important changes that are reflective of therapy, such as glycosylation changes, such as isotype shifts, in subclass changes over time. So partly we're limited by the biomarkers we have. So I think as we get better, we will be able to see changes in these levels that the overall levels may not drop, but the quality of the antibody may change. And we and others are working on that now, because I think that would be an important outcome in immunity and prevention. If you can tell that a pathogenic antibody has still there, but now changed to be less pathogenic, that'll be an important step forward.
Good. So Kristen, you presented some really interesting findings related to pregnancy and the onset of RA. What about multiple pregnancies? Are women with multiple pregnancies even at higher risk?
There's been a few studies that have tried to look at this, and it doesn't seem to be clear that multiple pregnancies affect the risk that much. There are data to support that any pregnancy, what's actually quite interesting is any pregnancy decreases a woman's overall risk of developing RA, but yet that postpartum period is a very high risk period. So something about the immune changes during that first year seem to be very risky changes, shifts of different kinds. But then if you make it past the postpartum period, there seems to be an association with an overall decreased risk, which is quite an interesting phenomenon. So nulliparity, having not had a pregnancy, is associated with an increased risk in the overall lifetime of a woman. And whether or not that's, there's not a lot of data on the ability to become pregnant in a woman who wants to conceive. And so, we have some questions that we hope to answer over the next few years also on whether or not is nulliparity associated with an increased risk of RA, because there's also something about those antibodies that's contributing to difficulties with conceiving. So there's a lot of questions in that area to answer. But yeah, it's quite fascinating that something about that first year is very risky, but then the long-term effects seem to be a decreased risk, and we don't really understand that.
Good. These neutrophil extracellular traps were of interest to a number of individuals as well. Tell us a little bit more what they mean in terms of prognosis or response to therapy.
Yeah, it's a great question. We don't know. We know they're definitely involved in rheumatoid arthritis. If you look in the joints of an individual with rheumatoid arthritis, there are many neutrophils that are netting. They seem to be associated with worse joint disease. As I mentioned, they can express citrulline proteins that are associated with these anti-CCP antibodies. We're the first group to look in the lungs and see that they're also present at these mucosal sites. And so we're certainly interested in how they're contributing there. With our work is to also look at whether or not they're predictive of who develops rheumatoid arthritis. But yeah, it's not, it's known to be associated, and exactly how and whether or not you can targeted as a biomarker or a treatment target hasn't made it to prime time yet.
Could inhibition of PADI enzymes lead to immunosuppression?
Yeah, I can take that with you. Yeah,
I'll jump in. There's potentially, and there's certainly industry is looking into that inhibition of the PAD enzymes as form of treatment. It remains to be seen how effective that's going to be and when exactly, when applied in the course of RA, that's going to be effective. But the idea is there, and there's some animal models that were actually published out of here where it does seem to ameliorate inflammation and autoimmunity in animal models. But we'll have to see how it works in humans. There's of course some concerns about, since PAD enzymes are ubiquitous and we need them for everyday living, how inhibition may lead to changes. So I think there's some concerns, but it's certainly an area of future interest.
Okay. In terms of the Stop RA study, reaching out to 30,000 individuals and screening them seems like just an enormous challenge. Tell us what types of how you have approached underrepresented minority populations in terms of reaching out to them and getting them to be involved in this research.
Yeah, so we have an interesting national approach to this that has some subtleties given on the area. So here in Colorado, we've partnered with the 9 Health Fair that has certain fairs that reach out to underserved populations, Hispanic populations, Native American populations, as well as African American populations. So we've specifically reached out to those certain sites to reach underserved people. There's certain aspects of that. Rheumatoid arthritis, as I mentioned, is prevalent in higher rates in indigenous North American populations. So we think benefit will be greatest in some of those populations, and we've looked at that. We're also partnered with a group in Oklahoma that has extensive tribal connections, and they've been doing great work in reaching out to Native American populations. We're also serving as a consultative role. Stop RA is not in Canada, but with some of the First Nations, indigenous groups there, they have, again, high risk. So it is a challenge. A lot of our research is based in the United States and doesn't reach these underserved populations, but we've had some unique opportunities.
Have you just reached out to the general population or relatives of individuals with RA?
So we do both. While having a relative with rheumatoid arthritis puts you at individually higher risk, in 90% of rheumatoid arthritis is what we call sporadic. So we've tried both. Certainly first degree relatives are a good target, both for increased risk as well as awareness of disease. And not to get too colloquial here, but if you grab a person off the street and tell them they have a CCP antibody and they've never heard about rheumatoid arthritis, they're going to be very much less likely to participate because they don't understand the disease. While a relative of someone with RA may be very interested. So we're trying all the approaches. This is part of where we're sort of forging ahead, learning as we go in the current trials. Next time around, we're going to have a lot better, I think, educational materials and insights in how to really accurately both identify people, convince them to participate in this study, and address those issues such as underserved populations that are both biologically interesting as well as good for society.
That's great. This work is really high impact work. I want to thank you both for what you're doing, and thanks very much for this terrific presentation.
Thank you.
Great, thank you.